This is going to be an intro to toxicology. I didn't have a lot of experience with toxicology until I got an emergency medicine and get to do rotations at a toxicology center. So anytime you deal with that, you should pick up the phone and call, at least giving them demographics. But they'll put somebody on the phone, a toxicologist, that can advise you on what potential antidotes, and a lot of it's a big game of investigation, trying to figure out what did that person actually overdose on, what can we do to save them from that. So, see an increase in exposure to narcotics. So, opioid overdose, obviously, what are they going to get? Pinpoint pupils, respiratory depression. So, not going to be sweaty, not going to be tachycardic, anything like that. Just be aware of that. You should be able to see what's going on with that. Versus, what if pupils are dilated? What are we thinking? Benzos or sympathomimetics, whether that's methamphetamine, cocaine, anything like that. So, again, this is just going to be an introduction. Here's your objectives. It's just 32 slides today. We'll power through and do a quick review for you folks. So again, here's your poisoning. It's usually exposure to that. We're going to see multiple systems affected in the body, usually multiple systems. Now these exposures can be from environmental, aka when we talk about organophosphate fertilizer, recreational or medicinal. So a lot of these usually ingested, so they consume it, but it can be inhaled. So through the mouth, it can be insufflated, aka snorted, whatever reason. Come in contact with the skin, mucous membranes, or via injection. So any different avenue will have a lot to do with the effect that it's going to have on the body. Here's your non-toxic ingestion. Now you have to hit all three of these criteria. So it has to be not intentional. It has to be clearly identified single substance. You have to have an idea of how much they've taken dosage-wise. So it's usually pretty difficult to determine that. And then it has to be a recognized information source that is on that. I want you to pay attention to. So if you do have to call poison control, it's 1-800-222-1222. 2. 3 2's in there. 3 at the start, 1 in the middle. So what do we want to try and find out? Hopefully that person comes in, they're lucid. Medications haven't kicked in yet. So my very first intubation was a 14-year-old young lady. Intentional TCA overdose, suicide attempt. And if you know anything about TCA, that's not the way you want to go. Tricyclic antidepressants, because there's really no antidote for that. So, and there's one case where we actually will do a whole valve irrigation. So this young lady actually survived, surprisingly. That's only because she got to the hospital quick enough that we were able to get pill fragments out of her stomach. But I want to get an idea of that. So hopefully they're lucid and they're with it and they can tell you exactly what they took and how much they took. Get an idea of what's going on with that. So you got to think about, why did these people take it? If it was an intentional overdose, probably a suicide attempt. And if anybody has read it all, you know, Tylenol overdose are pretty bad. Your liver essentially dies. You circle the drain for a week. And we have 8 hours to make sure that we get that NAC on board. So NAC is going to be the medication for that. But obviously this turns into usually multiple ingestions. Sometimes it's alcohol related. That's what they start with. Inhibitions go down, then they get serious and start taking medications. Figure out what's going on. What was the goal? Is there a psych history? Dealing with a lot of stress. And figure out what's going on. Getting as much information as you can from these folks. Were there any bottles that were laying around? Talking with the EMED. Hopefully a family member came along and was able to tell you what's going on. So we got to sort of figure those things out. We're going to look at the medication history. What do people have access to? What meds are they on? Availability of toxins, occupational hazards, using hobbies. Had a young man got sent back from Iraq to the emergency department when I was in phase 2 at Fort Stewart. He didn't tell me why he got sent back, but I went through his medical records. He was an IT guy and had access to cans and cans of the pressurized air to clean computers off. So he finally got himself hooked on it, to the point that they kept finding him passed out. He was just huffing. Got him cleared that night. So I go back. The next time I see him, he's coming in by EMS that morning. Had just left his psych appointment, stopped by the PX, picked up 3 bottles of canned air, and was heading out the gate when he crashed his car. He was huffing and driving. Big problem, big problem. Just be aware of that. People will get what they can get their hands on. And unusual smells. What does cyanide smell like? Almonds. There are toxicologists that come in and put on presentations and have you smell all different types of things, not at the real stuff, but what things would simulate it smell as. So just be aware of that. I want to make sure a lot of these folks, when we do a screening on them, we are going to get alcohol levels, we're going to get a urine drug screen to figure out what other type of substances they brought on board. And then we always ask, was there any home remedies? They try and make themselves vomit. Epicac, we don't do that. We don't want people vomiting, especially if it's some type of caustic material, and now it's going to come back up. It's going to be pretty bad, pretty bad. It's a great acronym for you. This is the Altered Mental Status acronym. And what I want you to pay attention to is that we're looking for A, there's alcohol in there, opioids, and then P, just generalized poisoning. Not really sure what that substance is. We're going to try and figure that out. Sometimes we can't figure out exactly what it is, but that's why we do poison control. To give you an idea of that. The other reason you're calling poison control is you want to give them some demographic data. So if they need to figure out what's trending, what's the new epidemic that's happening, what is everybody trying? Pick up the phone and call them, and we start looking at vital signs. Vital signs are going to give us an idea. If they're tachycardic, are they bradycardic? What type of medication do they take? We worry about little kiddos. They are visiting the grandparents. Grandparents typically have medications that the little kid gets a hold of or tastes, swallows, and get pretty serious. So we get these people trauma naked. We need to look and see, is there anything on their body that can tell us what's going on. Specifically looking for odors. Lots of people come in. Marijuana is pretty easy to smell. There's a lot of other different things. And we have what's called the toxicology handshake. That gives us an idea where to stick our hands inside somebody's armpit and see if they're basically, are they sweating or not. So does that give us an idea? What 2 things, whether that's a cholinergic overdose versus an anticholinergic. So if they're not having all those things happening, they're dry, probably took some type of antihistamine versus somebody that's sweating, that could be organophosphate or sympathomimetic. Just gives you an idea that we're going to look at pupil size. So serotonin overdose, a lot of times you're going to see that with nystagmus. But are they lacrimating? What's their reactivity? Are they meiosis or mydriasis? Gives an idea of opioid versus sympathomimetic. And getting an idea of muscle tone, tremors. All this is just going to kind of clue us in. Here's a good one for you visual folks. I'm not going to test you on this, but I told you, so bitter almond smell, cyanide toxicity. Meiosis can be anything from opioids, organophosphates, clonidine. What I've talked about tachypnea several times. What overdose do we see tachypnea with? I'm going to tell you because that's a phase 2 question. So aspirin overdose, salicylate. Now, it doesn't mean they're just taking aspirin. They could also be taking Pepto-Bismol, a ridiculous amount of it, or has salicylate in it. So tremors and gesticulations, we see that lithium. Hyperreflexivity or clonus, we're going to see that with serotonin syndrome. They're flushing, warm and dry, like I said, anticholinergic, that's going to be your realm of histamines. Warm and moist, sympathomimetic. probably tachycardic with that as well. Now, a lot of these people that come in, if they're coming in for a psych, for SI or HI, they're probably going to get a screen and all this stuff. Now, your drug screen is not going to come back quick enough for you to really make any clinical decisions on that. It's just an idea of what other medications they have on board. So, just realize a lot of false negatives, false positives with that, and it's not going to get back quick enough that you're going to be rapid after that. But we're going to get basic labs on these folks because we want to see if there's been any end organ damage, We always get an aspirin, always get a Tylenol, and we always want to get an alcohol level because we're so concerned about co-ingestions. Now this is where I told you I'm not a huge fan of the acute abdominal series, but in these cases it can be very useful. We start talking about people that are body packing, getting medications in an airplane across the sea from one country to another, or getting across the border. Be worried about body packing. What's another thing that you think might show up on an X-ray? Believe it or not, iron overdoses are pretty common because there's so much. People have a lot of that in their houses for whatever reason. That will show up on an X-ray. It is radio opaque. Those pills gives an idea of how much iron did they take. And then always get an EKG. TCA overdose will cause widening and then cause lethal arrhythmias. We want to get an idea if that's going on. And altered mental status in a child, always get a urine drug screen. And that is usually going to result in CPS being called. Those kids aren't supposed to have medications or anything like that. So you always have to consider CPS involved in that. Here's another read for the EKG. Breaks it down very good here. Lets us know. If you cannot figure out what medication is on board, we get an EKG to get an idea of that. And poison control is going to say, hey, what does the EKG show? Because if we start getting prolonged QRS, it could be any one of these medications. So there's your TCAs right there, which last-ditch effort. What do we give medication-wise to help this? I'll show you that in your next slide here. But just be aware, we're going to look at that QRS and see if is it prolonging. Is it prolonging? Greater than 100 milliseconds is what's going to be abnormal. And we worry about all these other types of things that are going on as well with bundle branch blocks, hyperkalemia that can accentuate these as well, can make them worse. So anti-epileptic drugs usually are the cause of this. I want you to pay attention to is what we call toxidromes. That's just a term for these different categories that all kind of show what we're looking for, specific classes of substances that are going to have specific symptoms that we look for to get an idea of what might be the antidote that we need. And I got a great slide for you here, and just to start some of the ones that I want you to pay attention to. Because we're open to, now this is about 250 pages on toxicology. So we're not going to get anywhere near that stuff. Just giving you an idea of that. Also paying attention to odors, anything that may be on the skin. Here's your toxidromes right here. So right there, you're anticholinergic. So mad as a hatter, dry as a bone. For those red as a beet. Versus your cholinergic, which is sludge. Acronym for, when I think cholinergic, I want you to think of nerve agent. Nerve agent. Okay, that's salivation, lacrimation, urination, diaphoresis, gastrointestinal emesis. Essentially what happens if somebody becomes exposed to a nerve agent. Got another one on there, right there, hypoglycemic, altered mental status. We worry about these people that have overdosed on their insulin. Had a gentleman come in one night, took his morning dose of insulin at night. Luckily, he caught it and came in. I gave him 5 amps of D50 just to keep him above 50, his glucose. If he'd gone to sleep that night, he would not have woken up. And that was an overdose. Unintentional, but still worried about that. And then we talk about a Narcan. people that overdose on heroin. And a lot of those folks, homeless, will stay right outside the emergency department in the event that they take too much. In the event they take too much Narcan is life-saving. I think the situation would resolve itself, but it doesn't. And then we also worry about sedatives. That's your own with benzos, alter mental status, bradycardia with those. I just have those starred because those are the ones I want you to pay attention to. Here's that number for poison control again. Always, always important. I get them on the phone as soon as I possibly can, so they can advise me what we have going on. So, and give them the 5 W's. They're going to help you with your resuscitation, as well as figuring out demographics, trends with poisoning, so that they can advise people in the future. Again, ABCs, first thing we need to do. So, it's not always reaching for an antidote right off the bat, but there are certain things that you have to reach for an antidote, and one of those is cyanide. You need to get a hold of this antidote as quickly as possible. So I'm going to put them on O2, and then amyl nitrate. I would definitely be very aware of what that antidote is for cyanide. Good chance you're going to see it again. Now we always get a glucose, so we want to make sure that if they are hypoglycemic, we can act upon that. They're not altered because of that. We're down that road. So blood glucose. Make sure there's potential until that Narcan gets on board if they are having respiratory depression. We go ahead and can bag them through that. So give them oxygen, bag them through so that Narcan can take hold. Had that police officer, so what he also had going on because he overdosed on sufentanil, or was exposed to it, not intentionally. So rigid chest syndrome, which is why you have to be very careful pushing fentanyl very quickly in the emergency department. You can cause somebody to go in that significant respiratory depression where they have rigid chest syndrome. So just be aware of that. Most of these folks, we may need to take their airway. We need to take their airway if they cannot control it. If they're hypotense, we're going to go ahead and fluid challenge them. 10 to 20 mLs per kilogram. I'm never going to ask you guys any dosages or anything, just that you pick the right antidote. Just be aware we don't want to overload them on fluids. And then consider if they are refracted to that fluid that you reach for a vasopressor, similar that you would for sepsis. Similar that you would in the sepsis case. All right, these are just some specific types of issues. Obviously, hypoglycemia, pretty simple. We give dextrose, pretty simple. Cardiac arrhythmias, what can we do with most of those types of things? So if we are having that QRS widening, we need to give sodium bicarb. Sodium bicarb to keep them from going into lethal arrhythmias. Sodium bicarb for QRS, so aka TCA overdose, we give a lot of that bicarb as last ditch effort. And then again, seizures, what do we treat most of those with? We talked about that. It's usually going to be benzos, what we reach for initially. So, agitation, also handle that with benzos as well. So usually Ativan. And there's our Narcan, aka naloxone, versus that hypoventilation. That is key. And then lipid emulsion, bupivacaine. That's why it's very important that you know your toxic doses for giving somebody anesthetic. I have had a lady come in after she had lipo done in Stone Oak, and her surgeon does not know how much Narcan that he gave her, but she came in classic bupivacaine toxicity, requiring lipid emulsion. Is the only thing that works. Had to be by the bedside in case she went into seizures. Just be aware of that lipid emulsion for those types of doses. I would definitely make sure that you review these next 2 slides. These are specific antidotes. I'll help you guys out with some check online. Some of these are pretty simple. Like you have calcium channel blocker. What do you think they need? It's taking too much calcium channel blocker. Calcium. Okay, some of these are pretty intuitive, not super difficult, but that's going to be given peripherally, which means we're probably going to give calcium glutamine versus calcium chloride. But just be aware of that. I would definitely be aware of what your cyanide antidote kit is. Some of these are pretty easy. So flumazenil for benzos. There's some other ones important. So thiamine, we're worried about people that are having way too much alcohol. It's affecting their brains. So what about isoniazid? What is that used for? Isoniazid. Okay. Somebody's been taking that for TB, so we're worried about that. It's crazy. You see what they the medication for that is? It's vitamin B6. And for undifferentiated, we're not really sure what's going on. We can't figure it out. This is a great acronym for us to use. So we have the DON'T cocktail. This is our undifferentiated. We're not sure why they're altered. They're starting to get comatose. We reach for it, just giving them dextrose. This is kind of in a situation where maybe you can't get a hold of glucose, you're out in the field. So we're going to put them on oxygen. We're not really sure what's going on. We're going to go use some Narcan. And then thiamine, if we're worried about either alcohol overdose or significant malnutrition. But this is an undifferentiated comatose patient. That's where we're reaching for this. We don't know what's going on. So I'm going to use that mnemonic. Don't, dextrose, oxygen, naloxone, thiamine. Unfortunately, I had a lot of Afghan soldiers seizing on my last tour. They were overdosing on heroin and any number of other things they were able to get hold of. Pretty sad, but had to have naloxone. Now, get into a little bit of decon. Your emergency department at your phase 2 site should have a decon room. Make sure you know what that is. You don't want to be looking for it when you're trying to decon somebody. You want to have found that before. So let's make sure that we can get the patient away from the toxin, whether that's all over their clothes, their face, their hands, whatever. Get them in there, get all that stuff off them, undressing the patient. Usually they have at least an eye station to rinse eyes specifically, but usually have a shower as well, because we need to get them rinsed off. If it's exposure specifically to the eye, we want to make sure copious irrigation. It's going to be a while. And they have special little lenses that can go on with IV fluid as well, if it needs to be continuous. Just be aware you may have to get a pH level on somebody to figure out if they're exposed to an acid. So sometimes we'll have to do tissue decon as well. Just be aware of where that room is. So blood and tissue decon, usually by urine alkalization with bicarb. And in some cases, we need to get these people admitted because they are going to require hemodialysis because it's a medication we do not have an antidote or a substance we don't have an antidote for. Decontamination required, especially if it's large exposure to the skin or toxic substance. But you also want to make sure you're being safe as well and getting your own PPE on. It doesn't help if you get exposed as well in the process of this. All that clothing is collected up and placed into a bag so it doesn't get any other exposure on anybody else and treated as hazardous waste. Here's your ocular. So it's possible that we do have to require some local anesthetics, so putting some drops in the eye. Tetracaine is typically how that's done. You're going to do that if you're going to be staining somebody's eye anyway. So just be aware that alkalis produce greater injury than acids, and that has to do with the liquefaction, necrosis. So a lot of times they have something called a Morgan lens. It hooks up onto an IV. So an IV line, and that can just be put in the eye to give continuous irrigation over hours. So again, we're going to check the pH on these folks, especially if they're exposed to an acid. We want to get that between 7.2, 7.4. That means it's not acidic anymore. And then anytime we're talking about live limb site, we're going to get ophthalmology on board as soon as possible. They need to be notified as soon as possible, especially if it's some type of damage that's going to occur to the eye. Other types of decon, right here, GI. So not hugely routine, but we're going to make sure that we're not having them vomit. We want to keep them from vomiting, especially if it's some type of caustic material. So I told you about gastric lavage. That's usually in conjunction with a toxicologist. They're usually in conjunction with a toxicologist. So usually it has to be within an hour of the ingestion. Otherwise the body's going to start breaking it down. So in conjunction with a toxicologist on that. Other things to reach for potentially, activated charcoal. Anybody ever seen somebody get activated charcoal? No? Yeah. Basically turns their entire mouth black. And it's pretty nasty stuff, but usually again within the first hour of ingestion. So, sometimes it can be mixed with water or juice. We can give it to via NG tube or OG tube. So this is going to bind with the toxin. We'll receive this aspirin, phenobarbital, carbamazepine, not things you're always going to see, but it's going to bind with this toxin and enhances the elimination via the stool. What we don't use it for, and be very careful, we don't use it in iron, we don't use it in hydrocarbons, lithium, lead, or toxic alcohols. This can be multi-dose as well. So toxicology usually supports this for meds that are slow release, so extended release types of things. There's your 5 different medications that we would consider using this for. Again, I don't know a whole bunch of people that are on these medications, so it's not very common, but still happens. Be aware of that. And then another way is whole bowel irrigation. So Miralax, and this is toxicology. You're talking with toxicologists. Toxicologist right across town is Dr. Sean Varney. Every time that I've called and talked to a toxicologist, he happens to be there. So he'll let you know, hey, we want you to go ahead and Miralax. Make sure we're giving them antiemetics. We do not want them vomiting this as it's going on. So right there, whole bowel irrigation, and our delayed release pills are sustained. We also consider this in people that are body packers, iron, lithium, leads, and then contraindications right there, and then your complications as well. So not very comfortable for somebody. Hopefully they're in a room that has a bathroom nearby. That's going to happen. These are getting in the realm of kind of last ditch efforts. We've tried everything else. We have to reach for this. There's another one, urinary alkalization. So we're essentially going to give that person bicarb. So we see that with salicylate poisonings. See it with salicylates as well. So sodium bicarb given usually over an hour, and then we're going to check the urine pH. That's going to essentially go from an acidic to get that to be effective. We want to make sure we're just monitoring for hypokalemia and volume overload. So, serial BMPs and checking that urinary output. They have pretty messed up exposures here when we have to reach for hemodialysis. That means that there's no other antidotes. We essentially have to try and filter out the body with hemodialysis. So removing toxins there. So you can even add that with charcoal filter. They have this over by medical center. There's not a lot of other places that will be doing this hemodialysis. This is last ditch effort. Overdoses, Gofflin, carbamazepine, paraquat. Not likely that you will experience this, but just know that there are other things. Toxicology would help out with that. Most of these people are going to be admitted. Because if it was an intentional ingestion, there's probably some psych on board with that. They were suicidal, potentially homicidal. So at least 6-hour minimum in the emergency department. Serial exams, labs, EKGs. Most of these people, if it was deliberate self-poisoning, they're going to need to be evaluated by behavioral health once that toxicology has been taken care of. Just be aware, one last thing to discuss, especially on the West Coast. It's like people that could be solving cures for cancer. Instead, they change a couple carbon atoms around to make a new medication, to make a new drug that the FDA can't even get hold of. So, have people getting off of planes from the Middle East, from Asia, and they're losing their mind. They're going into rhabdo because they're on some type of sympathomimetic, some crazy thing that's just going to cause their kidneys to shut down eventually. And there's not enough benzo in the world to slow that down. Just be aware there's newer and newer stuff, and people out there are like, well, what's that one called? That one's called Black Death. Ooh, I'll try that. It's just the nature of something. Do I have any questions on tox? We will get into